there is a lot on today with healthcare. As I said, over 4,000 medical procedures. They estimate about 4,300 are on hold today. 5,500 senior doctors are striking for 24 hours, along with about 370 odd nurses, till 1 minute to midnight. This comes after 8 months of failed negotiations. I'm going to get into that, but I'm also wanting to talk about the Primary Health Organisation caucus, also negotiating with Health New Zealand, and this is about the rising cost of providing care that's having a major impact on general practice. Despite the challenges, PHOs are optimistic about what could come out of these talks, especially after the government recently recognised primary care as a cornerstone of the health system. But with patient fees rising and many people delaying or missing out on consultations due to cost, the pressure is on this year's renegotiations to produce real change. PHOs say general practice funding hasn't kept up with rising cost over the years. A 2022 Sapere report found that $138 million was needed just to maintain existing services. That's it. That's just to maintain it. And since then, the funding gap has only grown. As a result, 1 in 6 people are reportedly skipping or delaying going to the doctor because it just costs too much. And that puts a strain on already stretched hospital services. Joining me now is the chair of General Practice NZ and general practitioner. We always love to catch up with him, Dr. Bryan. Good afternoon.
Oh, good afternoon, Leah. Nice to be here.
It is lovely to talk to you. Bryan, for those that don't know, can you explain what is the role of PHOs?
Yeah, look, PHOs, there's 30 of them around the country. Basically, general practices sit under PHOs, and PHOs sort of the middle layer between the government and the practices themselves. So funding flows through the PHOs to the frontline practices. The PHOs are responsible for what are called back-to-back contracts, so what is the expectation of general practice in terms of the government funding, but also PHOs have a remit around population health. So things like what's happening regionally in terms of service delivery, outside of frontline general practice, often things like immunisation targets, diabetes targets, a whole lot of other things. So they have responsibilities for the population, but also these direct contracting arrangements with practices themselves.
Okay, right, great. So negotiations, as you know, have started today, I believe, with Health New Zealand, and the PHO caucus says it is well aware of the fiscal environment. But do you think that this signals the government's recognition of the need to invest in improving access to GPs for general practice?
Look, it has been encouraging over the last few months that the government has indicated that primary care is a key focus over the next 2 or 3 years in terms of what's actually happening and how to stabilise frontline general practice and primary care services. There's a number of issues that have arisen in the sector. Underfunding over the last decade, a not fit for purpose funding formula, which is called capitation, which is, I think, is out of date and doesn't do what it needs to do, and increasing complexity with patients with an ageing population and deprivation, a whole lot of things that general practice is meant to be doing. So there does need to be focus on what's actually happening in general practice, or what we have seen started to happen is, and you've alluded to this, patients are having to pay more to see their GP because it's not fully funded. It's a mixed message. Yeah. And we now know that about 1 in 6 patients are saying, well, look, I'm holding off on seeing my general practitioner, although I need to, because I can't afford it. Now, if you can't afford to see your GP, the only place you can end up going to is an after-hours or emergency departments and hospitals presenting late, and that puts more pressure on the hospital services, which are already stretched. So real issues here that have developed in the system, but hopefully the government is now starting to focus on primary care and say we need to start to solve some of the problems that have emerged over the last decade.
You've mentioned capitation, and general practice capitation funding has not kept pace for the cost pressures over many years, as you've said. Can you explain to us how capitation works?
Yeah, so basically as a patient, 96% of the population are signed up with a general practice. So when you sign up to a general practice, what the government says is we will give you a fee, we'll give the practice a fee, X amount of money, over the next 12 months to look after that patient. Now, the money the government gives doesn't fully fund the running of the practice, which is why patients have to pay what we call a copay. So it's a mixed model.
Right.
So capitation is the system where per patient the government gives a fixed fee to the practice to help manage the patient and reduce costs for the patient.
Right.
Now, what we've seen with that capitation is it hasn't kept pace with inflation. So to give you an example, last year, costs went up by 5.88%, capitation went up by 4%, therefore there's a gap. Now, you can say 1% isn't much, but if every year that's happening, over 10 years, there's suddenly a 10% gap. And that's what we've seen happen. So it's just this fee that the government gives per patient, and there's this creep that's occurring where more of the onus is falling on the patient, essentially, to pay
Dr.
for
Bryan,
service.
we might have discussed this before. Do I get, so with my doctor, what the government gives, is it the same per person, or is it does it vary?
Look, it varies. It's quite a complex formula. The basic formula is based around age, a bit on what sex you are, and based on an average utilisation of general practice, about 2.5 visits per year. So what it doesn't take into account is complexity in things. So, with complex patients, they're often visiting sort of, 5 to, we have some patients visiting 20 times a year with very complex problems. The capitation doesn't fund that. So that's the problem we run into. There's a number of other little band-aids that have been put across it for different things, like under 14s are free and there's a slightly higher remuneration that occurs. If you're in a high needs area, there's a higher remuneration that occurs. But again, the basic problem with it, A, it's complex, but B, it doesn't cover cost. And that's the issue.
Do they get more, Bryan, if you get, say, more Māori or Pacifica or ethnicities at visiting a GP?
What happens is certain practices around the country that are called very low-cost access practices. So they tend to work in high-needs areas, often with high Māori and Pacific populations. So, for instance, my practice in Cannons Creek is called a very high-needs practice. We get a little bit of extra funding from the government to reflect the fact we have a very complex patient base that's highly deprived. However, again, we run into the same problem where it doesn't actually fully fund the service we need to deliver. So in areas of high needs, there is extra funding that go into these, what we call VLCA practices. But again, it hasn't kept pace with what's required.
You said it's slight, as it can be based on sex as well. Bryan, what about non-binary or people that don't?
Oh, no. So I just
there?
mean male or female. Look, they come into the funding formula. So it's a very small part. Okay. The main one is age, actually. The main one is age. Age is the main denominator. Yeah.
There's talk of a new capitation reweighting. I think you've touched on it, but that takes into account things like rural communities, deprivation, patient complexity. Does that give you hope then the funding might finally be directed to where it's really needed? Is that how it's going to work?
My view is we need to absolutely move down this track where the funding follows the patient. So if the patient's got multiple complex needs like diabetes and heart disease and mental health issues, and they're required to see the GP more often, then there's more funding attached to that. And it makes sense when you think about it. If you're fit and healthy and go once every 2 years, it's a very different situation if you're needing to visit 6 or 8 times a year. Look, there has to be what we call this reweighting, where these factors are put into play because they're not there at the moment. This work has been ongoing for the last 3 or 4 years on this. The government is still looking at this and working at this, and we need to be hopeful that they do move on this because it absolutely has to happen. We have to have a reweighting start to occur. We have to have a redesign of the capitation system that's fit for purpose and actually addresses the need that's out there, so that we can deliver the service that's required to keep people out of hospital.
Because, Bryan, you've already said, 1 in 6 are reporting delaying a visit to the GP or choosing just not to go. If negotiations didn't go well, we would risk obviously seeing that number rise, or doctors forced to put the cost up, and then that number's going to get even bigger.
Just an issue with the doctors putting cost up. That's regulated by the government. So GPs can't just put their cost up. The government determines how much they can put the cost up by. Now, what we have seen in the last year or two is if the capitation doesn't compensate for increase in costs, they're saying we will allow you to put up your cost, the patient copay, what the patient pays by X amount. So the government regulates that. It says this is what you can do. So it's entirely regulated in terms of what happens here. So yeah, and even with that, the argument from a lot of frontline practices is, look, even with that, we're still not covering our increase in costs here. And what is it is expensive to deliver service, and we're not covering costs. So it gets very complex at that point. But the baseline is, if the capitation isn't addressing need, then what the government allows the patient to pay goes up by more, therefore more of the burden goes on the patient. So that has been one of the issues that I think is a real issue going forward, and it's one that I'm hoping the government will address by looking at the capitation reweighting and the whole funding system, and that's really, really what has to happen here. Yep.
Bryan, I know this might, you might not be able to give me the exact figure because I understand it does gather. It'll change depending on where you are around the country. But I'm getting a few people, my listeners asking, they want to kind of know the average amount of per person for funding on a capitation, say a 45-year-old man in a central Auckland clinic or a female.
Yeah, look, that's a really hard figure to pull out because it is a bit of a myriad of different funding formulas that start to happen because all these stopgaps that have been put into play.